you need not do anything. But the importance is when it is associated with, what is this? Right bundle branch block. So whenever the PR interval is associated with what two things? Right bundle branch block or left anterofascicular block. I told you how to diagnose a trifascicular block. Right bundle branch block, fascicular block plus prolonged PR interval. So whenever the PR interval is prolonged in the presence of a bundle branch block, it indicates an advanced conduction system disorder. You must be careful. So this is the importance of first degree atrioventricular block. Second degree atrioventricular block, some P waves are conducted, some P waves are not conducted. It is called intermittent interruption of conduction. Intermittent interruption of conduction. There are two types of second degree heart block. Type 1 is called Wenke-Bach AV block, where you have progressive lengthening of RR interval followed by the block P wave. And the importance is the site of block in type 1 second degree atrioventricular block is at the AV node. So here the P waves are getting delayed and the P waves are getting blocked at the AV node itself. So type 1, the block is at the AV node, and most often it may not require treatment. Most often it is a conservative treatment for type 1 second degree atrioventricular block. It's called Wenke-Bach's phenomenon. So here what happens is the PR interval gets progressively prolonged and suddenly you find a P wave which is not followed by the QRS complex. Then PR interval starts normally, then it gets prolonged and then the P wave is blocked. So there is a progressive lengthening of PR interval before the P wave is blocked, which is called Wenke-Bach type 1 atrioventricular block. So how to approach this problem will be, first to identify the pass. First here the QRS complex is here. Here you suddenly find a pass, isn't it? Suddenly you find a pass there. So once you find a pass, see inside the pass the P wave is there or not. Inside the P wave is there. So it is what block? AV block. So once you decide AV block, see some of the P waves are conducted or some of the P waves are not conducted. So this is a second degree AV block. Once you decide the second degree AV block, see the previous PR intervals. If the previous PR intervals are gradually prolonging before it is blocked, if it is gradually prolonging before it is blocked, if it is, you can see that here in this cycle, P wave is blocked here, see the PR interval there, see the PR interval there, see the PR interval there. So before the blocked P wave, if there is a gradual lengthening of the PR interval, it is type 1 second degree atrioventricular block. The block is at the AV node. The block is at the site. Why this is important? Because you want to know where these P waves are getting blocked. The block is at the AV node. Whereas in Mobitz type 2 AV block, you will have no lengthening of the PR interval. The PR interval remains constant and consecutively get conducted. In spite of that, there is suddenly a beat which is not conducted to the ventricle. So it is the block P wave in the presence of constant and consecutive conduction. So if you see the block P wave, if you see the previous PR intervals, they are absolutely constant. There is no change in the previous PR intervals before the block P. It's type 2 second degree atrioventricular block. So once again you can see that here we first find a pass. First see the regular rhythm there. Here the QRS is not happening. See inside there is a P wave. So it's a AV block. Then see the previous PR intervals. They are absolutely constant. There is no change. That means this second degree atrioventricular block is Mobitz type 2. In contrast to type 1 second degree atrioventricular block, the type 2 second degree atrioventricular block is dangerous. The disease is in the distal conduction system, in the bundle branches and fascicles. Most often, this will predispose the patient to complete heart block and Stokes Adam attacks. So most often type 2 second degree atrioventricular block requires a pacing, the disease in the conduction system, distal conduction system. Type 1 second degree always at the AV node, usually benign, self-limiting, rarely progresses to complete heart block, usually associated with inferior valve myocardial infarction. Whereas type 2 second degree atrioventricular block occurs as a distal conduction system, more severe disease, progresses to complete heart block and Stokes Adam. Most often it requires a pacer. So that's why the importance of diagnosing whether it's a type 1 second degree or type 2. So the steps are identifying a pass, Inside the pause, find the block P wave, previous PR interval to be seen, progressive lengthening of previous PR interval type 1. If there is a constant PR interval, it is type 2. There it is in the AV node, here it is in the distal conduction system. Is that clear? Now we will go for the complete heart block before we go for a complete thought block. So at the end we will have a complete thought block. Before that we will finish off complete heart block. Right? So the third degree complete heart block is none of the P waves are going to be conducted. See that? All your P waves are going to be blocked either at the AV node or distal conduction system. For the heart to go on, you must have a secondary pacemaker which is coming in. Please remember that. So when the secondary pacemaker coming in, then you have a rhythm which is controlled by a pacemaker differently for the ventricle, and you have a beat, and when you have a sinus rhythm which is controlling the atrium. So similar situation like what? Ventricular tachycardia. Similar situation like a ventricular tachycardia where there is a single, one pacemaker is depolarizing the atrium, one pacemaker is depolarizing the ventricle. Only thing is here it is a bradyrhythm, there it is a tachyrhythm. So here you have an AV dissociation. Atrial rate is faster than the ventricular rate because sinus rate will be faster, but it is not going through the ventricle. Whereas ventricle, secondary pacemaker, rate will be lower always than the sinus rate. So here always the atrial rate will be faster than the ventricular rate. So escape rhythm maintains the life. So you can see that here. So here you can see just I am introducing the concept of supra-His complete heart block and infra-His complete heart block. For example, if the sinus node produces an impulse and the impulse goes through the atrium, depolarizing the atrium and coming through the AV node, and let us imagine all my impulses are blocked at the AV node. Because the impulses are blocked at the AV node, this block is called supra-His complete heart block because the block is occurring above the His bundle. So once the P waves are blocked here, what is the immediate pacemaker available to me? What is the immediate pacemaker available to me? Junction. Immediately the His bundle junction is the secondary pacemaker which is available to me. So if the P waves are going to be blocked, my junction will take over and start producing the impulse to protect the heart from the complete cardiac standstill. So the junction will start producing the impulse. Once the junction start producing the impulse go through what? Normal conduction system. So this escape rhythm will have what QRS? Narrow QRS. Although you have atrioventricular dissociation, because your atrial will be governed by the sinus node, now the ventricles will be governed by the junctional rhythm, but this junctional rhythm will have a narrow QRS. So if you have an AV dissociation and the escape rhythm has got a narrow QRS complex, that means your block has to be above the junctional pacemaker. It will be happening in supra-His complete heart block. So look at the CCG, basically a bradycardia, and the first important thing is to demonstrate an atrioventricular dissociation. See the P wave there happening here. It is on the ST segment in between QRS complex, just in front of your QRS complex, happening at the end of T wave. You see P wave is happening in different portions of your QRS complex. That is your atrioventricular dissociation. Here it's a bradycardia and the atrial rate is faster than the ventricular rate, telling you although the sinus rhythm is producing the normal rate, it is not able to reach the ventricle. The P waves are totally blocked. Then the ventricles are governed by this rhythm, which is also happening regularly, but rhythm has got what QRS? Narrow QRS means it is a junctional rhythm. That means your block has to happen proximal to this pacemaker. That means your block is happening at the AV node. So this is a supra-His complete heart block. So in contrast, if you have a block in the distal conduction system of bundle branches and vesicles, what is the next pacemaker available to you? What is the pacemaker available to you? Ventricle only. So only ventricle has to produce the impulse here, because no longer the junction is there, no longer other vesicles are there, it is the ventricle. So my pacemaker has to arise from ventricle. If the ventricle produces a rhythm, it is going through the muscle, it has got no access to the substantial conduction system. So this escape rhythm will have what QRS? White QRS. So if your escape rhythm has got a white QRS, you know that it is a ventricle is escaping. That means the block is happening at the distal conduction system. It is happening below the bundle of His. So it is called infra-His complete heart block. As you can see it here, first to demonstrate an AV dissociation. P wave is here, P wave is here, P wave is here. Basically absolutely no relationship between P wave and QRS complex. Atrial rate faster than your ventricular rate. Then look at the QRS width. QRS is wide. So because the QRS is wide, it is arising from the ventricle. So it is a ventricular pacemaker rhythm in the presence of an atrioventricular dissociation with the atrioventricular block. This block has to be infrahis complete heart block. So infrahis and suprahis complete heart block are decided by the escape rhythm. If the escape rhythm is from junction, it is suprahis. It is from the ventricle, it is infrahis. What is the importance of knowing whether it is suprahis complete heart block or an infrahis complete heart block? In suprahis complete heart block, your site of block is at the AV node. In infrahis complete heart block, it is in the bundle branches and vesicles. The escape rhythm is a narrow QRS escape rhythm in suprahis, wide QRS escape rhythm in infrahis. The rate is between 40 to 60 here, the rate is less than 40 here. It's a stable rhythm in suprahis complete heart block. It is an unstable rhythm because ventricle is not tuned for pacemaking. It is tuned for pumping. So if you ask ventricle to produce a pacing, it will not do correctly. It will not do it stable. So that's why the ventricular escape rhythm is unstable, and Stokes-Adam attacks are more common in infrahis complete heart block when compared to the suprahis complete heart block. Which second degree AV block will precede suprahis complete heart block? Type 1 second degree, because in type 1 second degree we told you the blocks are happening at the AV node. So when it becomes total, if at all the type 1 second degree is going to proceed a complete heart block, it will be a suprahis, which is a stable escape rhythm. That's why we told type 1 second degree escape block conservative management, because if at all is going to produce a complete heart block, it is going to be suprahis and stable escape rhythm, so you do not give an aggressive management. Whereas infrahis complete heart block, you will have infrahis complete heart block, we will have a type 2 second degree AV block will precede, and most common in anterior MI here because of the destruction of the bundle branches and vesicle. More common inferior wall MI here because right coronary supplies the AV node. So inferior wall infarction most often produces suprahis complete heart block because the AV node is involved. Anterior wall infarction most often produces infrahis complete heart block because bundles and vesicles are destroyed by the LAD disease. Conservative management here and the aggressive management with the pacer here. Good prognosis here, not so good prognosis here. That's why importance is to diagnose between suprahis and infrahis complete heart block. So this is a summary of all our atrioventricular block. Look at P waves and QRS. If all P waves are conducted with delay, it is a first degree atrioventricular block. In isolation, look for the drug history. When it is with the bundle branch block or a vesicular block, it is dangerous. When some of the P waves are getting conducted and some of the P waves are getting blocked, it is second degree atrioventricular block. So carefully look for the previous PR interval. If there is a varying progressive lengthening of previous PR interval, it is type 1 ventri-back phenomenon. The block is at the AV node. It may predispose, if at all, to suprahis complete heart block, in which Stokes-Adam attacks are uncommon. Whereas it is a previously constant PR interval with a block P, it is type 2 second degree atrioventricular block. The block is at the infrahis. SA attacks are common, so you may need to pace at this point itself. When none of the P waves are getting conducted and there is an atrioventricular dissociation, no relationship between the second degree with the P waves and the QRS, then it is a third degree atrioventricular block. Then look at carefully the escape rhythm. If the escape rhythm has got a narrow QRS escape rhythm, it is a suprahis complete heart block. Stokes-Adam attacks are uncommon, conservative management. If it is a wide QRS complete heart escape rhythm, it is an infrahis complete heart block. SA attacks are common, so you have to need a pacemaker implantation. So this is in nutshell your approach to all our atrioventricular block. So with that we finish the entire proceedings of today, but there is one more thing to go. What is that? It's an exam. So this has got a separate prize for this. Rajabal will finish off this and give this, finish off this. Last one is there. So just now I will stop speaking and you have to respond with your, first you have to respond to this particular AV block chapter. Yes, we'll rapidly go through that. The pass is where QRS is not found, P wave is not found, either, neither. Either. So pass is a situation in which the QRS is not found. When the P wave is, when the QRS is not found, P waves may be found. For example, in AV block, your P wave is there, still it is a pass. Only when the QRS is not found, it is a pass. When the P wave is there and is followed, not followed by QRS complex, it is a AV block which is contributing to that pass. So pass is a situation where the QRS is found. Inside the pass, you may still find a P wave which is not getting conducted to the ventricle. So pass is in which the QRS is not found, is pass. P wave may be still there. Pass with no P wave inside. Sinus pass, AV block, neither, either. Pass with no P wave inside. Excellent. So when there is no P wave inside, it is sinus pass. PR interval may be dangerous when longer, more than 240 milliseconds, when it is associated with inferior valve myocardial infarction, when it is associated with bundle branch block, when it is associated with the tachycardia. When it is dangerous. Yes. Good. So when it is associated with the bundle branch block, it has to, especially bundle branch block with fascicular block, it forms the trifascicular block. Site of lesion in type 1 second degree atrioventricular Wenke-Back phenomenon. Bundle branch, fascicle, AV node, his bundle. Yes. Excellent. So it is in the AV node and may predispose to suprahis complete heart block. Infrahis complete heart block, all are true except infrahis complete heart block. Site is bundle branch block and the fascicles. SA attacks are common. It is common in inferior valve MI, needs pacemaker. So which is not true? Which statement is not true? Right. Infrahis complete heart block. Excellent. It is common in anterval infarction. Inferior valve infarction is common in anterval infarction. So the CCG, you see there is a pass there. What pass this is? Sinus pass or AV block? Yes, respond. Excellent. There is no P wave inside. You see the pass. Is there a P wave inside? There is no P wave inside. So this is a sinus pass. This ECG is complete heart block. Atrioventricular dissociation is a complete heart block. Infra is complete heart block or supra is complete heart block? Yes. See, you must not take only the upslope of QRS complex. You see everything as a QRS complex. See, QRS complex starts from here and ends here. So I told you QRS which should be measured including the S wave. So you just see like this, you see the QRS complex, you think it is a narrow QRS, but there is a slurred S there. So if you include this S into QRS, the QRS complex is around 1.2 milliseconds. That's why when you measure QRS, you can see all the three. R, S, R dash, all the three has to be included. Right, it's little difficult, but include all the QRS complexes. Because I did not have 100% right answer this question. No question I had 100%, so you respond to this. So I want to have one question 100% right answer, so I don't find this is, I thought. 10% are not sure. I think they are involved in ECG class, confused about everything. So there isn't sure. Okay, that's for fun. Okay, now we'll have the toppers on this segments from tomorrow morning who gave the wrong right answers, maximum right answers. So there is a tie for the top spot. Oh, it's tie for everywhere. 151. Very good, excellent. 87. Yes. How to give the price now? Everybody is right. 124. 220. 86. Combined study, yeah? CD 5 Sorry, 5 5. This first 5. First 5 will get the prices. So we'll give some claps for these people. 60. Yes, good. 171. Good. 88. It's all combined study there, no? Right. So with this we go to the last segment. This is an exam. This is a full exam throughout the course. So there you have to respond right from the beginning to the end. Half an hour we'll finish off 50 questions. Then you have a separate big prize for this segment, and I request Dr. Rajan to bear with us for half an hour. So quickly you have to answer all these questions. I will not tell you the answer. Right, ready? First human ECG was recorded by S. Respond. Start. Right, William Enthoven. On the ECG paper, select the most correct answer. Time is represented horizontally, voltage is represented vertically. Time is represented horizontally and voltage vertically. 1 millimeter is equal to 10 millimeter. All of the above, none of the above. So the questions will be little more complex here, not as easy as the previous segments. Right, all of the above is the right answer. Right, then heart rate can be calculated from using the criteria following method. 300 by number of squares, 1500 number of squares, number of R waves in 10 seconds multiplied by 6, all of the above. All of the above is right answer. Rajabal, go to the previous question. So the previous question, many of you have said all of the above. You see the question, select the most correct answer. The most correct answer is time is there, voltage is there. Right? It is not the correct answer. The most correct answer in ECG paper is time is represented horizontally, voltage is represented vertically. So the correct answer is C, not all of the above. Right? Oh, that's what. So you don't want me to give all easy questions. Right? The absence of SA node impulse, pacemaker activity is taken over normally by AV node, AV junction, aortic valve. Yes. Which is a secondary pacemaker here. No, the AV junction is the pacemaking area. It is not the node. It is the junction between the AV node and his bundle is the one which is a secondary pacemaker. That's why we say junction rhythm. We do not say nodal rhythm. See, did you hear anything about nodal rhythm from me? I always said it's a junction rhythm. So it's a junction which is a pacemaker. It is not the node. Node delays the impulse, but it is a junction which produces the impulse. So the right answer is atrioventricular junction. Yes. On the ECG, electrical impulse coming towards negative deflection, going away is positive deflection, impulse going perpendicular recorded as equiphasic, all of the above, none of the above. Yes. Excellent. So C is the right answer. These two are wrong answers. Select the wrong combination. Bipolar lead L2, L3, L1, L2, L3, augmented lead AVR, L1 and AVF, chest leads V1 to V6. Select the wrong combination. Yes. Good. So it is L1 is not an augmented limb lead. L2 records potential difference between right upper limb foot, left upper limb left foot, right upper limb right foot, left upper limb right upper limb. Yes. L2 down and left. So somebody are confused now, left upper limb. So left upper limb, left foot is positive, right upper limb is negative in L2. Yes. High lateral surface is represented by which leads? Start. High lateral surface. Some of the questions are getting repeated, but doesn't matter. Yes, L1 and AVL. First portion of heart muscle is activated bundle branches. Start. Intraventricular septum, right answer. Intraventricular septal activation is what? Start. Left to right, right answer. All complex and negative normally in which lead? 100% answer for this alone. Yes. '98. Cartilage axis following leads are used. Yes. Right, all the limb leads. Next. Myocardial injury in coronary heart disease, which segment? Yes. ST segment. T wave is upright because repolarization is yes. Yes, depolarization the ventricle occurs from yes. So still have a confusion from epicardium to endocardium. So depolarization occurs from endocardium to epicardium and not from epicardium to endocardium. T wave upright is because of yes. Start. Yes, symmetrical T wave change, ischemia, digoxin, hypertrophy, bundle branch block. Yes. ST segment depression indicates coronary obstruction, that is near total, chronic total, insignificant, does not require any treatment. Yes, respond. ST segment depression. Acute near total obstruction. Earliest sign of myocardial injury. Horizontality. Acute myocardial infarction usually starts as ST elevation, depression, T wave inversion, no Q wave formation, new Q wave. Yes, acute myocardial infarction, our clinical syndrome of myocardial infarction. ST elevation. So it is ST elevation, not new Q wave formation. We are telling you as a starting as the ST elevation. Unstable angina, what change? Start. ST depression, right answer. Pathological Q represent? Yes. Next door myocardium, right answer. Pathological Q waves are deep, broad, 25% with leads which do not show Q, all of the above. Next, sorry, start. All of the above, right answer. Post-wall MI, which lead to look at? Start. V1, V2, right answer. Normal QRS duration. Still people have some confusion about normal QRS duration. Normal QRS duration is less than 0.0, not 8 seconds. In RBB, last portion of the heart muscle to be activated is, let's start. Rajabha. After this, we'll go to the straight ECGs. So right ventricle is the right answer. Can you do that? So with this, we go to straight to the ECG interpretation. So we have 25 questions. Now we show some ECGs for interpretation, then we'll finish off. Don't respond now, just give 2 minutes. So look at the ECG, see how many abnormalities are able to find out. The options are here, right atrial enlargement, biatrial enlargement or left atrial enlargement here. Look at the P waves. Look at the age of the patient. It's very important. What is this age? What disease patient likely to have in 28 years? What rheumatic heart disease? So commonly in this age, most often you find the rheumatic heart disease. Yes, respond now. See the terminal portion is wider, it is tall also, it is also wide here. So it's a tall and wide P wave. So right answer is biatrial enlargement. So this ECG, RVH, LVH both. Look at the ECG V1.